All right, welcome to Pharmacology First Lecture, chapters 1 through 5. We are going to start, it's on page 3 in your Roach's Introductory to Clinical Pharmacology book. We are going to just kind of today, hopefully some of this sounds familiar to you, just in being a mom, being, a young adult, you've taken medication. So some of the stuff I say today should not be completely brand new, and then we'll move into some specifics moving forward, okay? As I said, if you have any questions, type them in the chat bar. For the people watching that are not present in class on Teams today, or you're watching a recording, I will read those questions out so that we are all on the same page, and absolutely feel free to message me, outside of this if you have any questions. So let's get started. All right, so pharmacology is the study of drugs and their actions on living organisms. Knowledge of basic pharmacologic principles is necessary for nurses to administer meds safely and monitor the patients who receive them. So I had started yesterday just kind of talking a little bit, no matter where you work, no matter what setting, you're almost always going to be giving medications. Whether you work in a pediatric doctor's office, you're going to be given injections. If you further your career and you're a nurse anesthetist, you're going to be given medications. If you are, if you're working in a health unit, or you're working in pre-op, post-op, even if you're not physically giving medications, you are almost always going to be educating your patients on their medications, or you're going to be obtaining some information from them. So one of the things that I've learned in the last 13 years is that people are either willy-nilly about medications or they are terrified of them. There's not a whole lot of people in between. Like, you have some people who are like, oh, I got a headache, give me whatever you got. And then you have people who are like, oh, I have a headache, but I'd rather die than take a Tylenol. So you need to be able throughout your career to educate them as far as what their needs are and what is the accurate information. Just because they saw a commercial that said Tylenol is going to cause death, and taken in the right dosages, that's very rare, and we know that. So that's your job as a nurse. So that's the main thing we're going to talk about today. How can we use our knowledge to administer these medications safely, and how are ways that we're going to monitor them? So the biggest thing, you have got to be willing to talk to your patients. 90% of your information is going to come from you asking the right questions. Because if you say, hey, if you ask somebody in general, do you take any medications? They're like, nah, no, because they don't take them daily scheduled. But I guarantee you that everybody on this call has probably taken something in the last 2 weeks, whether it was Benadryl, whether it was ibuprofen, something for a snotty nose. We take medications, and a lot of times your patients are going to take for granted the medications that they take. And so as you're going to learn in pharmacology, some medications interfere with certain things. So it is your job to kind of be an investigator in the medication department and make sure that A, your patients are knowledgeable, B, your patients are taking their medications correctly, and if they're not, that you can educate, regarding all that stuff. So a lot of the things that I teach to are going to be not just the makeup of the drugs, but what you're going to do as a nurse, to be a better advocate for your patient and to keep your patient safe, okay? So medications in general, substances, they are substances that can be naturally produced, or they can be synthetic. So synthetic means that they were made in a lab somewhere. And natural, of course, means that they can be found in nature. So a good example, just to kind of look at it right now, is, they're beginning to use can't even think what it's called now that I wanted to tell you. Not marijuana, the other, CHG, or I can't even think of the initials. Somebody help me. But they're synthetically producing that in labs now, but originally it was found in nature, so that's an example of things, the way they're going to evolve over time. There's going to be stigmas that come with them, but no matter where they're produced, the FDA is going to have a big say in what these drugs are, their chemical name, their generic name, and all of the stuff. So let's go into those things. So drugs in general are given 3 names: chemical, generic, and trade. So I'm going to stand up. I got some things just to kind of show you guys. Let me get my little... I'm going to be using meal prep trays today, you know, since I'm not prepping my meals like I'm supposed to. I'll use them for medications to show you guys. So, all right, I have 3 medications here. All right, this one says children's pain and fever reliever. Let's see, I got to figure out which part of my camera to put it on. Y'all see it good? All right, so we have children's pain and fever reliever, and it comes in 160 milligrams, okay? And the name of it underneath the children's pain and fever is acetaminophen, okay? We have the DG, extra strength pain reliever, also acetaminophen. And then we have regular old Tylenol, also acetaminophen, okay? So y'all may know this, but I'm going to use this as just a really common example. So most of the time I'm cheapo depot, so I'm buying from the DG or I'm buying from Walgreens. I call them both Tylenol, but really at the end of the day, Tylenol is their trade name. That is the name that was given when they were first developed. So the FDA, actually, let me skip ahead to the next slide and then I'll go back to this one, okay? Let's see. I believe it's on the next slide. So the FDA is going to assign categories. So we have to go through an arduous process for these medications to be approved. So the FDA is going to give them a generic name. That is their name that's found in the National Formulary Drug Book. That is the name. The generic name would be, for this example, acetaminophen. The trademark name or the brand name is Tylenol. Tylenol was the first, or the people who created Tylenol were the first people that were given the rights to create this medication per se, you know, to produce it, manufacture it. So they got to call it whatever they wanted to as their trade name. But the generic name was given by the FDA. Does that make sense to you guys? So the trade name is also going to be called the brand name. It can be incredibly tiny. So the way we used to tell is it used to be capitalized. But the reason I wanted to show you guys this is because if you look at this one, can y'all see it enough to tell anything? The whole word is capitalized, right? So we used to say if it was capitalized, that was the trade name. Like, you know, Brendan or Catherine, that is our name, so we capitalized the first letter. That was the way it used to be for drugs. But somewhere along the way, they got away from that. So the thing that y'all need to look at to know which is the brand name and which is the generic name. So you can say generic is always going to be lowercase because it should be, but on packaging labels, it's sometimes not. If you look at this Tylenol, you're going to have to look incredibly closely or maybe look up something online. After, it's hard for me to mirror my image. You see after that L, that little trademark right in the top center? Can y'all see that from where you are? That is saying that this is the brand name, this is trademarked by this company. So I want y'all to know the difference. Does anybody know the chemical name for Tylenol? I don't even know. Let me Google it for you. These are the names that they give them in the lab that you are not ever going to hear, okay? Let's see. And what it is, it's the molecular makeup of the medication. It is the medication's, what molecules are made to build, to create it and stuff that's over my head. Let's see. Tylenol, chemical name. It is N4-hydroxyphenyl acetaminophen or something like that. So you're not going to see those names, okay? But know for the chemist out there that they exist and that they are used and in the combinations of creating these drugs. But we're not going to talk about the chemical name. We're going to talk about the generic name, and we're going to talk about the brand name, okay? As Americans, as a culture in general, I think that we pretty much all use, I say all, that's a blanket statement. Most of the time we say the trade name, even though we're buying the generic, just like with my cheapo depot Tylenol. Do y'all say, go get me some acetaminophen out of the cabinet? Or do y'all say, I need some Tylenol? So just like we do that with a common example like Tylenol, your patients are going to do that with their medications. So you might say, hey, I'm here with your atenolol, and they're like, wait, hold up, I don't take that. It's because they've memorized their brand name. So those are things you need to be mindful of moving forward. Don't just go in guns blazing and telling your patients that they're wrong, okay? So I'm going to go back a slide. Let's see. So we've kind of covered that. Drugs are given 3 names: chemical, generic, and trade. Drugs can be classified based on the chemical type or the way that they're used in the body. So let's talk about Tylenol. We take Tylenol mostly as most people take it as a pain reliever of some sort, right? So we would call it an analgesic, or we would call it a pain reliever. That is a classification, but it can also be used for fever. So we would, in that case, call it an antipyretic. So you don't need to know that, but you need to know that medications can have more than one, they can have more than one grouping. Does that kind of make sense to you guys? So like if you're taking an antifungal, it's an antifungal, but at the end of the day, it's also an anti-infective because you have a fungal infection. So when you're reading your questions throughout the semester, keep those things in mind for me. So don't get hung up on being like, no, that is not what that is. Tylenol is a non-opioid pain reliever. Well, it's also an antipyretic. So just kind of knowing that at the beginning helps. Let's see. So we talked about that. Drugs can be classified based on the chemical type or the way they're used in the body. Drugs can be prescription, non-prescription, controlled substances, or herbal preparations. So the FDA, they're your people. They are the Food and Drug Administration, and they are determining this. Now, when we get to controlled substances, I'm going to talk to you a little bit more. The FDA is not the only one that has any say in that. They communicate closely with the DEA to determine, what medications are controlled substances and whatnot. So we know about prescription drugs, right? We've all been prescribed something. What stands out with prescription drugs is you have to have a prescription from someone who is licensed to write that script. Your non-prescription drugs, you can buy over the counter. We also call them OTC drugs. Herbal preparations can be purchased over the counter as well. And then controlled substances are going to be substances that have a high potential for abuse. And they're going to be monitored very closely. That's the reason that you can't fill pain medications early. That's the reason that a lot of places you can't get Adderall from your regular primary care doctor anymore. It's because those are controlled substances and they need to be monitored very closely. So that's it on slide 2. Questions, comments, confusion so far? Feels pretty common, pretty common knowledge so far, right? All right. So after the FDA assigns these categories, we said they could be non-prescription, prescription, or controlled. They're going to go, they have to be approved by the FDA. So you can't just, okay, so let's take, all my examples are probably going to be COVID related. So COVID's going on right now. You have, if you play the stock market or whatever, you have stocks that are like skyrocketing right now because people are, trying to, or they're in the process of creating a vaccine for COVID, right? So for that reason, but before they do that, they can't just be like, I got it. I did my research in my own lab. I'm ready to produce this. The FDA has to put this drug through certain phases of approval. But for example, right now, so that's normally a 7 to 12 year process. That is solid, huh? So 7 to 12 years is usually how long drug development takes. But if you look in your book, I'm not going to go into detail about it, but if you look in your book, there is a streamlined process for situations such as what's going on right now. I don't actually know what page it's on. I'll reference it later. But anyway, so that process can be streamlined, but generally speaking, that process takes 7 to 12 years. So, that's a lot of times you know, it's just a very long time. So anyway, whoever develops the vaccine for COVID-19, the FDA is going to give that vaccine its generic name, but whoever the very first, group of company to develop it, they get to give it the trade name, okay? So the phases, we're not talking about streamline approval. We're just talking about regular approval. There's 4 phases. Like, let's just say I wanted to put out a new diet medication. That's not life or death. That's not something that needs to be, I mean, I might need it now, but that's not something that needs to be put out tomorrow. So this is the process that it's going to go through. Phase 1, they're going to choose 20 to 100 volunteers to see what the drug does to healthy tissue. So they're going to say, oh, Ms. Traylor, you want to lose a little weight? How do you feel about my clinical trial? I'll say, sign me up. Yeah, I want to lose some weight. They'll give me all the details. They'll say, I'm not responsible for this. We don't really know what it's going to cause. Sometimes they pay you money. That's phase 1. Phase 2, we're going to have tests performed on people who have the disease for which the drug might be effective. So then they're going to find some morbidly obese people, and they're going to say, okay, so you might have a few more underlying conditions. We've tried this on healthy people, but we want to see, let's see if it's effective, and let's see what happens, okay? Then in phase 3, the drug is given to a large number of patients in medical research centers that provide information about adverse reactions. So I had this conversation with my mama the other day. They put her on some medication. I'm going to talk about my sweet mama a lot. She's probably healthier than me, but she's almost 80. She's precious. I might have to even share a picture. But anyway, she's like, this says that it can cause acidosis in the blood. I'm like, Mama, you're not going to get, well, I shouldn't say you're not. That is very rare for something like that to cause acidosis in your blood. But during the FDA trials, somebody experienced that, or a few people experienced that. Therefore, it became one of the side effects. Does that make sense? So that's going to be one of your things you're going to educate your patients on too. Just because it's listed as a potential side effect doesn't mean it's going to happen to them. Doesn't even mean that it happened to a whole bunch of people. Just means that it's a possibility. It's also a possibility, that not to take any side effects lightly. I don't mean it like that. But it's also a possibility that I could get in a wreck on the way to work. It's a possibility I could lose internet connection during this meeting. There's a lot of possibilities in the world. So with drugs, you're always going to weigh out with your patients, with the physician, the prescribing physician, the benefits versus the risk, okay? All right, phase 4, post-marketing surveillance. So at this point, it is approved and it goes out into the public, but they continue to monitor. So this is where you see the commercials on TV where it says, if you took such and such and you now have a family member who died of a heart attack or got cervical cancer or whatever, those things were discovered in post-marketing surveillance. So in kind of wrapping that up, the FDA approves new drugs, monitors current drugs, and also informs the public of adverse and toxic reactions. Questions, comments, concerns about that slide? Feeling pretty good still? All right. All right, so let's talk about scheduling drugs in the United States. So remember we talked about, so the FDA has said, yes, this drug is safe. Yes, this drug is approved. So let's just use a typical drug. All right, let's do this. So Tylenol. Tylenol, we know, it's over the counter, right? It's not a highly addictive drug. We could take it 1 week, not have a headache, not take it again for 6 months, right? Everybody's taken Tylenol mostly in their lifetime. So it does not have, so keep that Tylenol in mind. All right, now let's talk about a prescription drug such as hydrocodone. Hydrocodone has acetaminophen in it, but it also has something combined with it, an opioid that does have a very high potential for abuse. So what happened, I mean, this is condensed version, obviously, but what happened with this was this new drug, hydrocodone, came out, and everybody said, oh, heck yeah, it's got Tylenol in it, but it works better than Tylenol. You know, it relieves my pain so well, da 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 da. So doctors were writing scripts for this. And then it started getting sold on the street. And then they started, you know, accidentally stubbing their toe so they could get hydrocodone. And so it became, we're going to talk about this way down the road whenever we talk about the opioid crisis, but it wasn't noticed in that first couple of weeks that hydrocodone had a high potential for abuse. That is something that was determined, you know, as time went by. So the DEA kind of stepped in. That's the Drug Enforcement Agency, I think. I don't even know. But they stepped in and they said, okay, hold on. You know, what is going on? Does this drug have a high potential for abuse? And they, in combination with the FDA, began to schedule drugs. So that way, if they pull you over and you have this in your car, not a big deal. If they pull you over and you have hydrocodone in your car that's not prescribed to you, it is a big deal. So that was a kind of way to join forces with the FDA and the FDA, the DEA, and then also pharmacies across the United States. These scheduling of drugs made it possible for us to better monitor the drugs that were being sent out into production. So because the DEA is involved, if you look on your slide there, obviously heroin, you can't go get a script for heroin, right? So you can't get a script for heroin, you can't get a script for ecstasy, none of that stuff, but they're still scheduled. That didn't come from the FDA, that came from the DEA. Does that make sense? So we still know that they're a Schedule I drug, but they weren't approved by the FDA. So they're not prescription drugs. So you can have a controlled substance that's not a prescription drug. Does that make sense? But you can also have a controlled substance that is a prescription drug, such as at the top, Vicodin, Oxycontin, Adderall. Those are controlled substances. They're not dispensed freely. They're monitored closely. So what you need to know forevermore is that if a drug is a Schedule I, the higher the schedule, the higher the potential for abuse. Everybody probably needs to say that out loud. The higher the schedule, the higher the potential for abuse. Say it a bunch of times. Maybe I said it wrong. Lord. If it's a Schedule I, if it's at the top of the tier, then it has a high potential for abuse. And as we go down, Schedule II, high potential. Schedule III, moderate potential. Schedule IV, low potential. Schedule V, the lowest potential, okay? Everybody feels kind of, y'all understand that? Y'all understand? So let's use that in practice. Let's say your patient was prescribed, your patient is prescribed Adderall, okay? Based on that chart, I just pulled this off the internet to kind of give y'all an idea. But based on that chart, if your patient said, I'm really kind of afraid that, you know, this drug might, you know, I might get hooked on this drug, your response as a nurse is not to say, oh, no, you're good. If your doctor gave it to you, you know, then you're okay. Your job as a nurse is to tell them to discuss that with their physician, you know, because it is a Schedule II drug. And when it's used appropriately, you know, and taken as prescribed within the safety realms, that's fine. But that, you know, sharing with others and all of this stuff is very, very dangerous. So you don't want to, you always want to hear your patient's concerns. You don't want to blow them off, but you don't want to necessarily educate either on stuff that you don't know a whole lot about. You want to point them to the right direction and educate accordingly where you can. So Schedule I drugs, high potential for abuse. Schedule V drugs, low potential for abuse. Those are controlled substances. Questions, comments, concerns? Okay. All right, so now I'm gonna pause. I'm just gotta get a little sip of water real quick because my mouth is getting dry. So regroup. I'll be back in like not even 2 seconds. Kitchen's right here. So now we kind of know how drugs are classified. We know how drugs are, who is in charge of these classifications. So now we're going to talk about the phases of drug activity within our body. So there's 3 phases throughout pharmacology. I am primarily going to be talking, well, maybe not. Well, we're going to talk about all the phases, but most of the time when we're talking about them, we're going to be talking about pharmacokinetics and pharmacodynamics. So pharmaceutic phase, the pharmaceutic drug phase, is when drugs are dissolved in the body. So what has to happen for this medication to be used, okay? So this is Tylenol, or actually it's DG acetaminophen. So right here we got this, and then this is also acetaminophen, but it's the chewables for my babies, okay? So these drugs, we would agree, this is a silly question, but we would agree that when they are sitting in this pan, they are completely useless, right? They're really nothing. They're nothing at all. So in order for a drug to be used by your body, in order for a drug to be effective, it has to be dissolved. It has to come into your body and be made useful. So the pharmaceutic phase is referring to how is that drug dissolved, how is it made usable within the body. So an example of that, so I have some other stuff here. So this is it's an elixir. So it's going to work a little bit quicker in the body because it's already dissolved, as opposed to something with a thick coating, like an enteric coating, that has to make its way to the stomach and be broken down before something can happen. You're all kind of with me there? So that's pharmaceutics. So how do y'all think something that's an injectable, y'all think it's going to dissolve more quickly or more slowly? Y'all can answer me out loud. It's only 10 of y'all. Quicker, because it's already dissolved, right? It's already going directly to those tissues where it can be used. So that's really all pharmaceutics is referring to. So we're not going to really talk about that whole lot. We will be talking about the route of administration, and that is what's included in the pharmaceutic phase. What route we're giving it in. So pharmacokinetics, anybody take kinesiology before or heard of kinesiology? So it talks about movement, right? Kinesiology is referring to movement. So pharmacokinetics is the transportation of a drug throughout the body. So if I just put this on my tongue, I got nothing, right? If I swallow it, goes to my stomach, and from my stomach, it's sent out to my tissues, then we're making some progress, right? Something can happen. So pharmacokinetics, what I'm going to do, I'm going to skip the last one, and we're going to go on, and we're going to talk a little bit about pharmacokinetics. All right. Let's see. I'm going to skip this next slide because I think I already told you that before I even talked about it. Okay, pharmacokinetics. I want y'all to remember ADME, A-D-M-E. Okay, those are your 4 phases of pharmacokinetics. So this is how your body is, this is the order in which drugs are moving through the body, right? So ADME, A-D-M-E. First phase, absorption. That's how it's made available for us. So as it is dissolving, after that first phase, as it's dissolving, we're going to absorb it. So let's just talk about our stomach. And I'm going to, I don't know if dumb this, I'm going to make this very simplified. Everything that I say is happening a little bit more complicated within the body, but you don't need to know all of that stuff to understand what pharmacokinetics is, okay? So if you really want to read in depth and all that stuff, you can. But I just want you to know that absorption is, or that all the steps that I'm talking about, if you know where they take place and things that affect them, that's going to be the stuff you need to know, okay? So first absorption. So absorption is the rate or absorption is how the medication is made available to us. So medication, we swallow it, it goes into our stomach, it absorbs, right? We can't do anything with a whole pill, but when it absorbs, all of the medication that is in it is made available to our bodies for use, okay? So when it's made available, so some things that might affect absorption, if you have a full stomach versus an empty stomach, like let's think about drinking, just to use an example. If you have an empty stomach, how fast is your body gonna absorb that alcohol? I know y'all all drink, so no, I'm kidding. So if you have an empty stomach, you're gonna absorb it a whole lot faster, right? You're gonna feel the effects of that alcohol a whole lot sooner. That is absorption. So same way goes if you have problems with your stomach, which I know y'all learned A and P, y'all talked about, different, how the stomach is made up and all the layers and all this good stuff. But if you have stomach issues, if you have anatomy issues, or if you have an empty stomach, or if you have a full stomach, all of those things are going to affect absorption for an oral medication. So same way, if you're getting an injection in the arm, my arm is kind of thick. I got some subcutaneous tissue. I maybe, will distribute it a little bit different than somebody who weighs 92 pounds. Y'all see what I'm saying? So that is how it's made available to our body for use. Distribution is how is this medication going to bind to proteins and transport the site. How is it going to bind and get transported to the site where we're going to use it? So distribution has a lot to do with our circulatory system, okay? We're moving medication from point A to point B. Metabolism is when your body changes the drug to a more or less active form. So your body is going to metabolize the drug that you were given, and it's going to make it, attachable. It's going to use it. It's going to attach with the tissues. That's where the activity is really going to take place, okay, as it's metabolized. And then excretion is when we're going to eliminate the drug from our body. So we're going to talk, I think I've mainly told y'all this stuff, but now that it's on the correct slide, I'm just going to kind of read through it again and elaborate if I need to. I get into a habit of talking ahead of my slides. So for absorption, the drug particles within the GI tract are going to move into the body fluids. So it's kind of the first step on that train. The factors influencing are going to be the route, which we talked about, and the solubility of a drug, which we also talked about. The first pass effect is when a drug is absorbed by the small intestine and the liver first metabolizes the drug, and the remaining drug is not enough to produce the therapeutic effect. So an example, this is kind of the best example I can think of for that. Y'all ever taken like a Z-Pack and like azithromycin, and they tell you to take 2 pills the first day and then 1 thereafter? That first day, they give you a higher dose because your body metabolizes it a lot faster, okay? So that's absorption. Distribution, we talked about, has a lot to do with your circulatory system. The drug is distributed to various body tissues and target sites. We'll talk a lot more about target sites and how the drugs work when they get there at a later point. And then once they're there, those drugs are going to interact with specific receptors in the body. And that is how your body knows what to do with the Tylenol, okay? It's how it knows, that it's not just there to be pooped out, that it can be used and can be bound to something. So quick distribution, heart, liver, kidneys. Slow distribution, internal organs, skin, and muscle. So I won't go into, we're going to talk about that a little bit more too as far as the distribution rates when we talk about routes. So I'm not going to go into that a whole lot right now. All right, metabolism and excretion. Metabolism is when the body changes the drug to a more or less active form. So that's where the action's taking place. And excretion is the elimination of the drug from the body. So y'all remember from A and P, y'all, when we excrete, most of the time we're urinating, right? That's how we get rid of most of the waste in our body, is by urinating. So your patients who have crappy kidneys, they're going to excrete a whole lot slower than your people with healthy kidneys, right? So some drugs are metabolized in the liver. So different drugs are metabolized different places. Most drugs are broken down by the liver, but some of them are distributed in other ways. So it's important as we learn about these drugs to know which drugs are highly metabolized in certain areas, because we're going to in turn know your patients who are most at risk for those meds, or most at risk taking those meds, and you're also going to know your patients who you know shouldn't take those medications, and you're going to know what to monitor. You know, if you know that it, like, I hate to get into too many drugs right now, but just know excretion, we're going to be thinking a lot about kidneys. We're going to be thinking about how fast can they rid this of their body as a healthy person can. So patients with kidney diseases would naturally require dosages that are reduced and careful monitoring of kidney function. As you learned in A&P also, older adults, as adults age, our organs just don't function as well. They get a little tired, and they're just a little slower. They don't work as well as they did when we were younger. So older adults are also going to be at an increased risk. I'm starting to get tongue-tied. At an increased risk for excreting medication slower, and then, than somebody else. You feel good so far? Yeah? Okay. Yeah, I'm gonna flip my chair over. That'd be awful, huh? Let me get straight. All right, let me make sure that I did not get ahead of myself over here. So on page 8 of your book, there's a pretty good little, if you're a visual person, on page 8, there is all the phases. So you have your pharmaceutic phase, your pharmacokinetic phase, and then your pharmacodynamic phase, which we'll talk about later. You just kind of want to look at that as a reference. Of course, I told y'all key terms are always incredibly important. When I have extra time at the end of my lectures, I talk a lot. I might not ever have extra time, but I'm gonna always throw those out at y'all and make sure that you're not taking for granted words that I assume that you know. Okay. Always in your book. If you go reverse to page 5, it's the first one that I see. Those nursing alerts are incredibly important before we move on to the half-life of these drugs. So nursing alerts, you always need to make a note of them. Remember I told y'all about the accelerated programs. I'm sorry, I should have reviewed this before I went on to metabolism. Remember when we talked about the FDA-approved drugs, and I said there's some accelerated programs that can be found on page 7 of your textbook? Okay, so before I go into half-life, I wanted y'all to open your book to page 8, and I'm gonna talk about some important terms that are in here that I want y'all to make note of. Okay. So when we go into the phases, talked about the pharmaceutic phase, we were talking about the pharmacokinetic phase, the drugs moving through our body, right? So we talked about absorption. There's a few things that I want to, there's a main statement that I want to point out that you need to always remember. The rate of absorption, several factors influence the rate of absorption, including the route of administration, the solubility of the drug, and the specific conditions of the body tissues. So that's on page 9. So the reason that sometimes students struggle, not just with pharm, but in nursing in general, is they'll say, oh, nobody told me that. That wasn't in there. This is an example of where you have to use what you already know. So based on that statement, several statements influence the rate of absorption, including the route of administration, the solubility of a drug, and the specific conditions of the body tissues. If you had a select all that apply question, and it said something to the effect, I'm pulling this from nowhere, so I might butcher it, but if it said something to the effect, which of the following might affect the rate of absorption, rather than listing, including the route of administration, your teacher might say something like whether the medication was given intravenously or orally. You'll understand that that's the same thing. And so yes, that would be correct. This the specific condition of the body's tissues, you would say, poor subcutaneous circulation. That's something that would absolutely affect the rate of absorption. So as you're on your exam, I just wanted to stop and give you all that little tip. Don't just memorize those things, but when you're looking at them, think about, okay, what does this really mean? What does this statement really mean? And then you'll be able to answer your test questions, okay? All right, so that's what I wanted to tell you about absorption. Distribution is the systemic circulation transporting drugs to various tissues. Distribution of drugs absorbed in the body depend on protein binding, blood flow, and solubility. So if your patient is, severely malnourished, their protein is going to be depleted. Therefore, their drugs might not bind appropriately, so they won't be distributed as they should be. Okay, so metabolism. Let's see, we talked about that mostly. I don't need to say anything about that. I would like you to make note that most drugs are metabolized by the liver, although the kidneys, lungs, plasma, and intestinal mucosa sometimes aid in the processing of these drugs. That can be found on page 9. Now, the thing that I don't think I included in your slides, bear with me. Oh yeah, I did. I thought I left it out, so that's why so I can go back to your slides now. So when you're reading in your book, pick out those statements and determine what you feel is the most important, okay? All right, so the half-life. You're gonna see, I don't remember much about NCLEX, but I know I had a half-life question on the NCLEX. So the half-life of a drug is the time required for the body to eliminate 50% of the drug. So let's think about this in, I wish I could get a way for y'all to kind of communicate with me. So a drug with a short half-life is going to be administered frequently. So let's say I'm going to just I'm totally making up numbers, okay? Let's say that you have, I should have made examples ahead of time. So let me just use my hands, forget about dosages. So the time required for a body to eliminate half of a drug. So if I take Tylenol, right, and I have a headache, the half-life is whenever I have the medication in my body and half of it is gone, that's how they know that when the next dosage can be safely given. So some drugs, so Tylenol, for example, it has a short half-life because I can take it up to 6 times a day. But other medications, such as extended release medications that are only once a day, they have a very long half-life. So if, I know I have an example for this, so bear with me. I'll do better tomorrow and have my examples already. Let's see. Let me get you. Okay, here we go. Half-life refers to the time for medication in the body, refers to the time for the medication in the body to drop by 50%. Liver and kidney function affect half-life. It usually takes 4 half-lives to achieve a steady state of serum concentration. So what that means, when you're starting to take a new medication and your patient says, well, I took the medication and it's not working, it's because they took it and then the half-life was over and they didn't take it again. But if they take it and then they take it at the next time the half-life is almost over, and they take it at the next time the half-life is almost over, then they will eventually, after about 4 half-lives, they will maintain a continuous dose as per the required recommendation. Does that kind of make sense to you guys? I'm gonna give y'all an example where it can, where it'd be a little bit more tangible. But so it usually takes 4 half-lives to achieve a steady state of serum concentration. So that's why if I have a sinus infection and I take 1 dose of antibiotics, I'm not going to feel anything. I'm not going to feel better. So I'm not going to call my doctor after day 1 and say, hey, I still feel like crap. I'm going to take it again, and I'm going to take it again. And by day 3, those half-lives have been equaled out to the point that I am now at a therapeutic range. So if a medication has a short half-life, they leave the body quickly. And they will have a short dosing interval, which means you can take them every 4 hours. If they have a long half-life, medications will leave the body slowly over more than 24 hours. And these drugs with a long half-life, this is the stuff I want y'all to write down. Drugs with a long half-life have a greater risk for medication accumulation and toxicity. That makes sense to you guys? Because if it takes 16 hours for half of the medication to be out of your body, you're a whole lot more likely to accumulate than if it takes 4, okay? That's pretty much it. But half-life is a very important term for y'all to know. I had some examples that said, like, if the half-life is, let's see. I'll find it. I'll post a little half-life example question, because I know if I make one up myself, I'm going to butcher it. But be on the lookout for that. We're going to do a half-life question, because that's something that's always seems to be brought out on the NCLEX. Okay, half-life. Okay, so knowing when drugs will start working. The onset of action is the time between drug administration and the very first therapeutic effect. So that's that time when you have a terrible headache and you take your Tylenol. When about 40 minutes later you start feeling it, that's the onset of action. That's pretty self-explanatory. The peak concentration is when the absorption rate equals the elimination rate. And the duration of action is the time for the drug to produce the therapeutic effect. Okay, there was supposed to be a link from the library there. I'll also attach that. It just explains that in a little bit. It's pretty self-explanatory, but I'm visual, so I like stuff like that. So I will make myself a note how drugs work. Link. All right. I'm going to go way back. Okay. So back to our first slide. We talked about pharmaceutics. We talked about pharmacokinetics. Everything I just told y'all was pharmacokinetics. ADME. Absorption, distribution, metabolism, and excretion. Okay, that's the order. Those are pharmacokinetics. The next thing we're going to talk about is pharmacodynamics, which is the study. We're fixing to take a 5-minute break because my mouth is dry again. Pharmacodynamics is the study of the drug mechanisms that produce biochemical changes in the body. So pharmacodynamics is more, how is your body breaking this down for use, right? So pharmacodynamics is kind of the part of pharmacology where you're like, oh, I don't really care what it binds to and what receptor, just tell me what it does. But when you know those things, you can better educate your patients, right? You can keep them safe. You can, it just makes sense. Like if you know, I'm the kind of person, if I know I am learning, I told y'all I didn't like statistics. If I know that I'm learning statistics to make me better at XYZ, I still haven't figured out the point of statistics, but that's neither here nor there, then I am a whole lot more apt to be like, oh yeah, that makes sense. Yeah. And then I can further educate people, you know, I learned this and this connects to this and that's where pharmacodynamics comes in. If you're understanding, you know, how it's working within the body and you have an understanding, then you can say, okay, this is why. This is what's going on. This is why you're not feeling it yet. This is, you know, why you're more tolerant to this drug. We'll talk to the doctor about that. So don't check out when we talk about pharmacodynamics, okay? Because it does have a purpose. On that note, though, we are going to, y'all want like a 7-minute break, get something to drink? Actually, or y'all want to just rock and roll? Y'all want to rock and roll? Okay, I say rock and roll too because it's different in the classroom. You can get up and walk around. But I guess there's really nowhere to go since we're doing this in person. So I'm just going to keep rock and rolling if y'all are good. All right. Let's see. So I just wanted to go back so y'all can see the phases of drug activity. So now we're going to be talking about pharmacodynamics. Okay, I want to read this little blurb to you. Pharmacodynamics describes the interactions between medications and target cells, body systems, and organs to produce the effects. Now, want me to repeat that? Pharmacodynamics describes the interactions between medications and target cells, body systems, and organs to produce effects. These interactions result in the functional changes that are the mechanism of action for medications. Okay, so when you're doing your drug cards moving forward, you're going to have to put, I didn't share an example of a drug card. Did y'all use drug cards at all last semester? Okay, so drug cards, I'll talk about that later. But on the drug cards, there's going to be several. It's going to say the classification. It's going to say the generic name. You know, it's going to ask you all these questions. And one of the questions is mechanism of action. And that is simply saying, how does it work? What does it do? You know, why is it used for this? So we have, let's see. So drugs can work in one of two ways. They can cause physical changes. So one thing, let's sunscreen. Let's talk about that. Sunscreen can cause a physical change on the surface of the skin that is going to block those certain rays of the UV or UA, I don't know. It's going to block those rays. It's going to cause physical changes on the outside, right? It's not changing the chemical composition of your skin. Does that make sense to y'all? You're putting it on, it's blocking something, so it's causing a physical change. So that is something, like I said, like sunscreen. Or, you know, I'm not going to go into the drugs specifically. Sunscreen is the most, I think, tangible example of that. Drugs can also work by changing things chemically. So they can, so let's talk about the stomach. Anybody? I'll be impressed if you do. Does anybody remember from A&P, like the pH of the stomach? Type it in the chat bar if you remember it. Okay, so nobody's jumping on that question, but that's okay. So the pH of the stomach, we know it's acidic, right? Everybody would agree the stomach is acidic? Yes? Yes. Okay, the stomach is acidic. So if we put something that is alkalytic in the stomach, we are changing the chemical makeup of that bile. Am I correct? acidic plus basic, we're neutralizing, right? So medications that do things like that, they are altering the chemical components. They are making a change that is deeper than physical changes such as sunscreen, right? So they're going to inactivate certain cellular functions. So when we have heartburn and we have all this acid, when we have acid indigestion and we take an antacid, we're changing the chemical makeup of our stomachs, therefore reducing the acid, therefore reducing that symptom that we're feeling. So that's an example of a chemical change. Both physical and chemical changes, we're altering the cellular environment somehow, right? We're changing what is normally going on within that cellular environment. So, what was I going to tell y'all about that? So, those are two ways that we can alter the cellular environment. I don't know what else I was going to say, but I'll come back to it. Okay, that's one way. Other ways, we can interact with the cell. So, instead of changing it completely or blocking something, we can interact with those cells. So drugs can interact with receptors, which is what determines the function of a cell. Drug molecules join with reactive sites on the surface of a cell. So we're going to talk about this kind of like, I thought it was on here. Let me look on the next slide. Okay, no, it's not. I'll try to find it. I want y'all to kind of think of this, like I'm going to use my hands a lot because I don't have anything physical to hold in front of y'all if we were in class. Receptors are going to bind together, right? Like, so if you have I need an example. Oh no, I feel like everything I think of looks not appropriate. All right, hold that thought. I'm going to read this to you. Antagonists bind to or mimic receptor activity. For example, morphine is an agonist because it activates the receptors that produce analgesia. So your body has receptors, and these receptors are waiting for a response from somewhere else, basically, okay? So whenever it receives a signal, it'll say, oh, this is a pain signal, and it's going to bind to it. This is just kind of a concrete example for y'all. But when we give an analgesic, that analgesic medication binds to that receptor. So when the pain comes in, it can't attach to that receptor. Does that make sense? There's a binding that takes place that's going to block something else. So that is an agonist. An antagonist just blocks it altogether. It joins, but it doesn't stimulate receptors. And it affects the number of available receptor sites. So this, I'm going to make a note. I have a whole better slide on this that I thought was on here. So we're going to come back to this. We're going to come back to agonist, antagonist, and partial agonist. And I'm going to post a video, and we're going to visit that in the morning because I want to have a really good example and show you guys. I apologize. I thought I had that stuff in this slide and with me. But we're going to know this. We're going to know, this is all I want you to take away from these slides right now. The way drugs work I have a good little YouTube video. The way drugs work, they are going to somehow alter the cellular environment, either physically or chemically, or they are going to interact with a receptor on that cellular site. And the different types of reactions with the receptors are agonist, antagonist, and then there's a partial agonist that's not mentioned on here. So learning what those things are is going to be very important when we talk about opioids. So opioid agonists are going to bind, and then opioid antagonists are going to block different things. And I'm gonna give y'all a really good YouTube video. If I don't send it out tonight, somebody shoot me a reminder, okay? Because I don't want to go into depth with y'all on that until y'all watch that video, and I don't want to take our class time looking for it. Okay, so factors that influence drug response: age, weight, gender, disease, and route. So we have kind of already touched on these, right? So males, Why do y'all think that gender might affect anything? Do y'all know?
Like because of like weight or body distribution, like
Yes.
that stuff?
Very good. So that's perfect. That's exactly the answer. So, men and women, we're about right now, or not right now, we should always be about, but, equal rights, and men's bodies are made differently than women's bodies. They generally speaking are more muscular in nature. So their distribution is going to be different in a man versus a woman most of the time. So very good. Weight, obviously, the smaller, your smaller people are going to need generally a smaller dosage, right? Not always. Now, you're going to have some people that just don't fit into these categories, but these are the categories that are mostly going to influence drug responses. So routes, y'all type in the chat bar just so I could get some interaction, because I know it gets boring listening to me talk for an hour. Tell me what y'all think might be one of the fastest, tell me a disease that might significantly affect how someone responds to a drug, based on what I told y'all about metabolism. Have y'all learned a lot of diseases or not yet? Kind of, sort of. Don't be afraid to type anything. Liver disease. Beautiful. Okay. So good job, Essence. So if somebody has cirrhosis of the liver, which y'all will learn more about, do you think that they might need a higher dosage of a medication or a lower dosage of a medication? No judgment. Y'all type it in the chat bar. If their liver is shot, they're going to need a lower dosage of medication. So where this comes in with your prescribers and with your nursing judgment, so sometimes that lower dosage of medication might not be therapeutic, right? Like a half a Tylenol, I'm just keep referring to Tylenol because I got nothing else. A half a Tylenol is a lower dosage, so it's safer for your patient, but it might not be effective for them, right? So that at that point, that's when we determine, is a different drug, and I say we, the physician, the prescribing physician is going to determine this, but a lot of times you're the go-to person that says, hey, my patient said ... what do you think we should do about this? So age, so we haven't talked about babies much. This is, I'm glad this, I wanted to tell y'all an example. Factors influencing drug response. So I had a medication error this week. I didn't make it, luckily. Well, I took part in it. I'm going to tell you the whole story. And I want you to think about age and weight. Think about them together. Don't think about them separately. So both of my girls have peanut allergy, or tree nut allergies and peanut allergies. So I'm always stressed when we go back to school because I have to get 17,000 papers. It's really just like 5, but it feels like 17,000 papers filled out that say they need a medication order. And then we have to go to the pharmacy and, of course, get the medication. And the medication label has to, to a T, fit exactly all of what the paperwork says. And so everything has to be just right. So I have an 11-year-old daughter who has been allergic to peanuts. She was my first allergy baby. So she has had an allergy. So she has had an EpiPen since she was 3, 2 or 3, something like that. She's had an EpiPen since she was 3. So she has had an EpiPen Junior since she was 3 years old. She just started the 6th grade. And when she went into the 4th grade, it is the very first year that she switched from an EpiPen Junior to a regular old EpiPen, okay? EpiPen Senior. The dosages are different, okay? Do they look pretty much beyond colors? What y'all think? They look pretty much the same, huh? Other than colors and reading the dosages. So my 11-year-old just switched from an EpiPen Junior to an EpiPen, from an EpiPen Junior to a 0.3 regular EpiPen when she was in the 4th grade. So my 6-year-old, she just turned 6 last week. We went and got her prescription filled. And when I was at the pharmacy, we are a small town, we know everybody knows everybody. She said, hey, she didn't put the dosage on Maddie's EpiPen. She needs a junior, huh? Because that's what I've gotten filled. This is the baby. She said, she needs a junior, huh? And I said, yeah, because she's gotten a junior every time. Her sister got a junior all the way up until she was in the 4th grade, and my baby girl just started 1st grade. So I said, yeah. Didn't think anything about it. No doubt in my mind that she needed the junior, right? Because of her age. She's only 6. My other daughter didn't use the other one until she was 9, but I didn't take into account her weight. My 6-year-old is 70 pounds. My 11-year-old was not 70 pounds until she was in the 4th grade. So anyway, we make it to the school. We're filling out the paperwork, and the pharmacy calls me, and they're like, Brittany, you got to come back. I'm like, what? They're like, we gave you the wrong EpiPen. It didn't match the order. You know, they trusted me because I was a nurse. They trusted me because my daughter's been on this. And so I made the error of, instead of saying, I don't know, I was like, yeah, EpiPen Junior for sure. So I left the pharmacy with the wrong EpiPen for my youngest daughter because although she was 6, her weight changed. So that is a huge factor in drug response, because had we not changed it back to the 3, if she had an anaphylactic reaction and she got the EpiPen Junior, would not have been effective at all because it's only half of the dose of the other medication. So y'all see in regular life how, I made that complicated, but in telling the story, I could have simplified it. But anyway, y'all see how it happens super easy. And it just didn't even cross my mind that my 6-year-old was having an adult dosage of epinephrine. Like, that just seems absurd to me. But based on her weight, it's completely accurate. So had the pharmacy not gone back and checked that as they did, and I spoke out of turn and said, yeah, EpiPen Junior, so all of those things, no crisis. We traded it out, the right EpiPens at the school, all the orders matched. But at the end of the day, had she had an anaphylactic reaction, that could have been a life or death situation, simply based on an age and weight discrepancy. Okay, so those are absolutely factors. We talked about disease, we talked about age and weight, we talked about gender, and we talked about route. Oh, we didn't really talk about route, but it will definitely, the route, if it's injectable, it will be much quicker than an oral medication. So the route will influence the drug response for sure. All right, drug reactions. There are several types of drug reactions. Let me see what page we're on in our book so y'all can follow it. Everybody still good? Questions, comments, concerns? Let's take, I don't want to take a break, but somebody tell me, raise your hand in the chat bar and tell me about I know I don't like to talk too much, but I can't talk for 3 hours straight. Tell me of a way that, like a drug error or something, a factor that influenced the drug response for either you personally or in your family, or can y'all think of any examples kind of similar to mine? Putting you all on the spot. Nothing. Can't use all my examples in the first lecture. Nothing, honey. Okay, y'all stink. All right, so we'll talk about drug reactions then. If y'all don't have any examples, if y'all think of any, shoot them to me. Drug interactions. All right. So we have drug interactions and we have drug reactions, right? Drug interactions is when a drug interacts with I'm just skipping through to see if I have it on here. Okay, yeah, so we're not going to do that. We're going to skip to slide 20. Y'all see, this is a slide that y'all see say drug interactions. Okay, I would rather talk about drug interactions before I talk about drug reactions. So drug interactions are when one drug interferes with the action of another drug. So one of the biggest examples of this is, does anyone know anybody who was taking birth control and took antibiotics simultaneously and had a little baby 9 months later? Are any of y'all those people? So that is an antagonistic drug interaction. The one neutralized the other, and so it was no longer effective. Okay, so a drug interaction doesn't have anything to do necessarily with your body responding. A drug is responding to another drug. That's why it's called a drug-drug interaction. So it's an interaction between drug A and drug B. So examples of this, and you're going to learn about all of these drugs, but anticoagulants, which are, for lack of better term, blood thinners, hypoglycemics, which are medications that are going to lower your blood sugar, anti-infectives, which is the antibiotic example that I gave, antiarrhythmics, affect your heart rate. All of those medications have a strong chance of interacting with another medication. So it's important in obtaining information from your patients to get an accurate drug list because, okay, so let's talk about I'm going to use the antibiotic example a whole lot. So, your patient has been on birth control since she was 19, okay? And so she don't even really consider it a drug anymore, because she's been taking it for so long. So when the primary care doctor, she went in with a sinus infection and he said, hey, do you take any medication? And she's like, no, nothing. I'm healthy. Don't take anything. Because she just kind of sidestepped it as a medication. And she was prescribed antibiotics. And then she had a baby. And then she's like, hold up. We missed a key. We missed some information. We forgot to delve a little bit deeper to say, hey, what medication are you on? So it's very, very important to get an accurate list of your patient's medications so that you can be on the lookout for drugs that might interact with one another. You're not going to know these all by heart. I'm going to try to teach you as many as I can, obviously. You're not going to know them all by heart, but you're going to know the biggies. You're going to know that your patient doesn't need to be taking, anything that can significantly thin their blood along with a lot of over-the-counter NSAIDs. You're going to know stuff like that, and you're going to be able to educate to it for sure. So these are just some examples. An additive effect, an additive drug-drug interaction is when one drug plus another drug, it just increases the action of that drug. So heparin plus alcohol will cause increased bleeding. So 1 + 1 = 2. A synergistic drug interaction is when you take one drug and you take another drug, and instead of 1 + 1 = 2, 1 + 1 = 3. So drug A plus drug B combined together produces a sum greater than alcohol and heparin combined, like the first one. When you take an additive drug, it's heparin can cause increased bleeding, alcohol can cause increased bleeding, so the two together can cause increased bleeding, right? Synergistic is when you take something and then you take something else and it's like off the charts. Your chance of something happening is off the charts, So a lot of times that would be like alcohol and hallucinogenic drugs. Like if you're taking antipsychotics and you combine that with alcohol, that's a bad combination. You see what I'm saying? Like it's more than an additive. It becomes a sum greater than the two alone. And then an antagonistic, we've already talked about. That's your antibiotic example, is when one completely neutralizes the effect of the other. All right. So just like you have drug-drug interactions, you have food-drug interactions. So food may impair or enhance a drug's absorption. We talked about that at the very beginning. If you have an empty stomach, you're going to absorb a little bit faster, generally speaking, than someone who has a full stomach. And that's just based on the absorption of the medication. Let's see. You can have the you need to take into account food-drug interactions because some drugs might irritate the stomach. They might cause nausea. So the drugs that cause nausea, we're going to be sure to educate our patients to take them with food, right? The drugs that cause, I can't really think, like anti-coagulants, alcohol is a food, right? Technically, it's something you consume. I guess you could say it's a food. We're going to say don't take alcohol with this because it can have a food-drug interaction. So drug-food mixtures is when drugs combine with food forming an insoluble food. So like we're going to learn about whenever we learn about antibiotics, you can't give tetracycline with dairy products. It's been known to cause that food drug mixture causes problems. So know that there are going to be interactions when we learn about warfarin and cumin, and we're going to talk about leafy green vegetables. There are definitely things that are going to interfere with the drugs that you take outside of other drugs, okay? All right. So let's go back to our reactions. Drug reactions is how our body responds. It's not drug A plus drug B. It's what our body does when it comes into contact with a medication. So we want a therapeutic response, right? We want when we take a drug, we want to experience relief from whatever we took that drug for. That is considered a therapeutic response. The drug did what it was supposed to do. A drug reaction is your body reacts or responds differently to the drug than was anticipated, or there was some kind of negative response to that drug. So drug reactions can be allergic drug reactions. You can have drug idiosyncrasy. You can have drug tolerance. You can have a cumulative drug effect, toxic reactions, and a pharmacogenetic reaction. So those are your types of drug reactions. So allergic reactions usually begin after more than one dose of the drug is given. So sometimes you might be administered an antibiotic. Your child might be administered an antibiotic, and with that first dose, they do okay. And the second dose, they do okay. And the third dose, they break out in hives everywhere. And you're like, it can't be the antibiotic because I already gave it to them twice. So that's not true, because allergic reactions sometimes take more than one dosage of the drug, before they actually cause a reaction. So signs and symptoms of allergic reactions. I feel like most people have had an allergic reaction or seen an allergic reaction. Itching, skin rashes, hives, wheezing, cyanosis, loss of consciousness, swelling of the eyes, lips, or tongue. So the risk of an allergic reaction is that it advances to anaphylaxis. Anaphylaxis is when your body goes into like shutdown mode. It's hypotensive, there is that cyanosis, loss of consciousness, swelling of the throat. That is anaphylaxis. So an allergic reaction can be mild. Anaphylaxis is not mild, okay? Anaphylaxis is like on the far end of the spectrum of an allergic reaction. Okay. All right. So these other reactions, pharmacogenetic reactions are inherited traits that cause abnormal metabolism of drugs in patients with certain deficiencies. So these drugs are very, if you have a pharmacogenetic reaction, your body makeup, your genes don't respond with that drug well. That is on a very deep level, your genes. There's a gene problem and there are deficiencies within your genes, so they can't bind to receptors, or they bind to the wrong receptors and it causes problems. Idiosyncrasy is an unusual or abnormal reaction. So an example of an idiosyncrasy, Benadryl usually causes a normal side effect. I hate to use the word normal, but y'all know what I mean. A normal side effect of Benadryl is drowsiness. You take Benadryl, it makes you sleepy. That is a side effect, and that is expected. An idiosyncratic reaction would be if it wires you. If you give your kid Benadryl and they're like running around the house like a psychopath, they've had an idiosyncratic reaction. So it is not life-threatening, but it's not what was anticipated. It's unusual, abnormal, strange, or weird, okay? So it too is believed to be caused by a genetic deficiency, but pharmacogenetic reactions are absolutely caused by genetic deficiencies, okay? So I don't want you to get those confused. Just think idiot, weird, abnormal, idiosyncratic, or idiosyncrasy. Toxicity is when a drug is administered in large doses and the blood concentration levels exceed therapeutic levels. So we want therapeutic levels. So let's talk about therapeutic levels real quick. You have subtherapeutic, which you took the medicine, but it didn't do what it was supposed to do. You have therapeutic levels, you receive the desired effect, and then you have toxicity, and that is when you have gone above the therapeutic levels and it is now dangerous to your body. You're toxic. So some drugs have, let's just talk about therapeutic levels really quick. Some drugs have very, very narrow therapeutic margins, or you have to be between this dose, this very, very narrow dose for it to work. And if you're outside of that dose, then you're toxic. And if you're below that dose, then you don't have, you're not doing any good. An example of that is like vancomycin. Drugs like that, you are going to measure and make sure that your patient is within that narrow range so that they're not toxic. If they have a wide therapeutic index, then they're safer and that risk for toxicity is lower. That makes sense to y'all still? So drug toxicity, if something is given in toxic levels, then we need to give a reversal agent. We need to somehow reverse that and bring it back down to a therapeutic level or dissolve it completely. We do that by administering an antidote. That's an important term that you'll need to know. Antidotes are given for drugs with low safety margins. Okay. Let's see. I'm going to give y'all some time whenever we end the call. Let me make myself a note. I know it's awkward to communicate, especially with people watching, from other locations. I know it's awkward to communicate on here. So I am going to be adding in some like discussion questions that are they're going to be homework in a way, but it's going to kind of be more for me to know that you looked into stuff afterwards. So if I add like a random discussion question that says, find an example in your book of an antidote, that'll just give me a way to know that that I know that I made a point to tell you that that's important. You need to know those kind of things. So if you see random discussion board questions pop up, I'm going to use those throughout, and you can kind of use those throughout the semester as a study guide. I'm probably not going to go through them with a fine-tooth comb, but I do want y'all to think about these lectures after we leave the lectures. I don't want it to be like the lecture's done, so I'm done. I want to throw some stuff out at y'all so y'all can think about it as the evening goes on. So anyway, if you see a random discussion question tonight, that's why. If you don't complete it in the morning, it's not going to be a crisis, but we're going to talk about them at the beginning of our meetings. And that way we can all kind of get on the same page and use some real life examples. Otherwise, y'all are going to get really, really sick of me talking for 2.5 hours, okay? Okay, so back to reverse. So toxicity. Antidotes are going to be administered for drugs with a low safety margin. Is anybody, probably y'all don't, huh? Does anybody know an antidote offhand that they've ever had to receive an antidote, ever had to have a family member receive an antidote? I'll give y'all just a few seconds in the chat bar. Yes, perfect. Thank you, Kelsey, for, okay, so Narcan. Narcan is a perfect example of an antidote. So Narcan is given for opioid toxicity. For opioids that are given in excess, we give Narcan as an antidote for those drugs, okay? And we give it, sorry, I lost my slide. So if you don't know what Narcan is, it's a drug that reverses, it's an antagonist, which we'll talk about that. I want to save that, but we're going to talk about it's an antagonist that is used as an antidote for opioid toxicity. All right, so drug tolerance. Drug tolerance is a decreased response to a drug. It requires an increased dosage for a desired effect. So I had a patient, I did hospice. Y'all are gonna, a lot of my examples are gonna be hospice related. So I did hospice and I had a little fella, he was ate up with cancer. He was a pretty young guy, he was probably in his 50s. And he had cancer and he was on a pretty solid amount of medication. He was on a lot of narcotics. But when I tell y'all he couldn't get out of bed, he was in a great deal of pain. His history, he was a prior drug user. So he had a very high drug tolerance to the medications that we were giving him. So essentially, in comparison to our other patients, we weren't giving this guy anything. You know, he was so tolerant to the drug. He had such a decreased response that he really needed an increase in dosage. So what we did for him was we got some of his previous records and we were able to see, wow, he was on this medication when he was at this hospice in Florida, and we were able to get him, to a therapeutic level for him personally, because he had such a tolerance. And so you need to be mindful of that. The same, even though weight and age and all of that comes into account, prior usage of drugs and your patient's drug tolerance is going to have an effect on the medications that they're receiving as well. And then a cumulative drug effect, a cumulative drug reaction, is when patients with liver and kidney disease, their body is unable to metabolize and excrete one dose before the next dose is given. So a lot of times this happens in elderly people. So they're given some medication. Like, let's just say we have a wild woman in the LTAC, and she is climbing out the bed and she is just wild. So we give her some Ativan per our physician's orders. And her kidney and her liver disease is, it's not significant, but she's older and they're slower. So that night she's getting a little bit wild again. And so they give her another dose of Ativan. And what happens is, exactly like this says, the body is unable to metabolize and excrete one dose before the next dose is given. So it accumulates in the body. So on night 3, your girl is out. Like, she ain't climbing out the bed. She is zonked to the world, and her family thinks she's dying. It's because Monday night and Tuesday night, we've accumulated these drugs in her system, and we need to give them some time to clear out. So that's a type of reaction that you need to pay attention to as well. All right, so allergic reactions, drug idiosyncrasy, drug tolerance, pharmacogenetic reactions, toxic reactions, and cumulative drug reactions. So let me ask you a little question. Type them in the chat bar. Which drug reaction, or you can holler it out to me, it doesn't matter to me. Which drug reaction can, in its worst form, can lead to anaphylaxis? Very good. I'm starting to see them come in. Can y'all see, just curious, can y'all see y'all's peers' responses or only your own? You can see your peers. I'm gonna have to hide that because I want y'all to feel free to answer me and not be scared of getting it wrong. So I'll figure out how to hide that. So yes, allergic reactions can advance to anaphylactic reactions. So let's see, what two types of drug reactions? One is definitely related to genetics and one is thought to be related to genetics. Which two? Good job. Idiosyncrasy and pharmacogenetics. All right. Let's see. All right. So based on everything that I told y'all, your job as a nurse. Your job as a nurse is to consult appropriate references and the hospital pharmacist. So remember I told you we want to educate our patients, but we don't want to educate them wrong. So did everybody, I don't even know if it's on y'all's syllabus, honestly, but I think y'all were told for clinicals, does everybody have a drug book or a drug app on your phone? You won't be able to use your phone at clinicals. So does everybody have a drug book, like a lookup drug book? Like not one of your textbooks. Does that ring a bell at all? No. Okay. So I'll shoot out an email tonight. You can order them. You're going to find them in clinicals to be extremely helpful to you. And you can find them online. I'll send y'all some links. You can find them on Amazon pretty cheap. But basically, and it's all available on your phone. It truly is. But in the clinical setting, you're not going to just be able to whip your phone out and pull up a Davis Drug Guide in your phone. So having a book that you can hold in your hand is going to be helpful to you. And within that book, remember I told y'all you were going to do drug cards. We were going to talk about drug cards and stuff like that. Within that book, you're going to be able to find everything about that drug. You're going to be able to find the therapeutic range. You're going to be able to find special, I don't have one here with me because I'm at my house, but I'm going to the office today, so I'll bring some tomorrow and show you some different examples and send you some links. Let me make myself a note. And also, if I tell you that I'm going to do something in class and I don't do it, somebody send me a reminder. I won't get mad at you, okay? Drug book. Because y'all need to be comfortable looking up stuff and we want you to be incredibly knowledgeable when you leave this class, but we don't want you to assume that you know everything. So there are references out there that you can refer to that will be helpful to you. So in the hospital setting, when you're giving medications, most stuff is computerized Mars now. There's a little tab at the top. So if you're given a medication and you're like, I don't know, I'm not sure, that seems like a really high dose based on what I've given, you can just click on it and it'll be like a little drop down and it'll say, appropriate for this weight and da 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 da. So your job as a nurse is to know what your resources are, consult those appropriate resources and references, not WikiHow to give meds or, I don't even know, just random Joe Blow Google the correct and appropriate references and your hospital pharmacist, okay? Using your judgment is going to be incredibly important in giving medications. So like our little lady, for example, that we talked about with the Ativan. Your judgment is going to be based on knowledge that you have, and sometimes you're just going to have a gut feeling that that's just a little too much medication for that little old lady 2 nights in a row. And you need to trust that, and you need to, she still needs what she needs, but you need to talk it out with somebody, talk it out with your charge nurse, push your brains together and make sure that we're doing exactly what is the best thing for your patient. You need to observe your patients. So if you gave a patient a medication for the very first time and they said, last time I took it, my eye was a little itchy, but nothing ever happened. I didn't get any hives or anything. Are you going to wait 6 hours to go see your patient? You should never wait 6 hours to go see your patient, but are you going to wait 2 hours? Or are you going to maybe pop your head back in 30 minutes and make sure their eyes aren't swollen shut? You see what I'm saying? Observe your patients, use your brain. Accurately observe and evaluate the circumstances. So not every circumstance is the same. So like I talked about, trying not to repeat myself, but I just want to drive it home when I talked about my daughter, just because my oldest daughter didn't use a 0.3 milligram EpiPen until she was almost in middle school, doesn't mean that my youngest daughter didn't. That was a different circumstance, and that was poor judgment on my part. That was an assumption on my part, as was it an assumption on the pharmacist's part. And we can't make assumptions in medication administration, and I know that, and I still did it. So not getting too comfortable and not taking drugs too lightly as a nurse is your job. You have to record what you do. If you don't document that you gave a medication, you didn't give it, and it got given, that's my new word for the day. It got gave twice. So if you don't do that, then, you didn't do your job as a nurse if you didn't document that you gave the medication on the MAR. And then, of course, you need to report, if any of those drug interactions or reactions occur, you need to report those to the prescribing physician, okay? I'm not going to just hang out and see what happens next, right? We're going to report that, and we're going to get some direction. Let's see. So I want to go in depth tomorrow. I'm going to share the YouTube video that I'm going to be sharing, I believe is about 20 minutes. The one about agonist, antagonist is a great visual. I would prefer for you guys to watch that independently. So that's going to be part of today's lecture time. So I'm going to post that link. Hopefully it's in my old Canvas and I can pull it up rather quickly, but be on the lookout for a link. And I'll post it in an announcement, because y'all's announcement should go to your email. So I will post that in the announcements. I want you to watch that. And it's about how drugs work in the body. And then I will elaborate a little bit more on it tomorrow, but you can just really visualize with the receptors a whole lot better than you can with my hands and all this stuff. So I want y'all to watch that tonight. That's kind of your, I'm going to call it homework, even though it's not on the overview, because we are going to be ending class here shortly. So I definitely want y'all to watch that. Something else I was going to tell you guys. I'm going to go over these key points, and we're going to answer a few little chapter review questions together, and then we'll be finished with this call. Before we go over the key points, this was just an intro, basic pharmacology. Does anyone have any questions? I love questions, so please ask them. I'm gonna exit from my PowerPoint so I can see some of y'all. Let's see. Oh, I wanted to tell y'all, in the modules, my PowerPoint, sometimes when you're just looking at it, it does not pull up. You have to download it and open it, because sometimes I don't really know what it has to do with anything, but sometimes it looks glitchy on there. So at the top, there's a download button. If you download it, you'll be able to see it clearly as I presented it today. Okay. Questions at all? Y'all feel okay? Everything kind of made sense today, I think. Tomorrow, the plan, I'm going to be lecturing from the classroom, Lord willing, because we're doing math tomorrow. So Lord willing, I'm going to be able to write on the smartboard, and you're going to be able to see it just like you saw my PowerPoint today. I'm going to go practice today after we get off this call. So wish me luck. I ain't real tech savvy. So I'm going to do that today. So that's the plan for tomorrow, is we're going to go over some math. And if we have time, we'll get into chapters 2, 3, 4, and 5. Wanted to tell y'all too, as far as exams, don't get stressed out that it's so many chapters at once, because a lot of the information is going to overlap, okay? A lot of the information is going to be pulled from one chapter and implemented into the next chapter. And so don't get totally like, I can't, it's too much. All right, so remember I told y'all yesterday, or for the people who are watching outside of my accelerated course, I had told them yesterday the key points in the back of your book are great starting point. If you can read the key point and it you feel like you've heard it before, you're doing pretty good. If you read the key point and you're like, what? I've never heard of that in my life, then you need to go back in your book and you need to reread that section, okay? So key points. I just want to make sure they all sound familiar and we don't have any questions. Pharmacology is the study of drugs and their action on living organisms. Yes? Yes. Each drug has several names, a chemical name, a generic name, and a trade name. Sounds familiar? We know how to tell the difference between trade names and generic names. Showed you an example of that. Try to find some in your medicine cabinet. And, you know, find me some examples. I love examples, or send me a question, picture, something. Find as many real life applications as you can, because you're gonna do better if you can touch it, feel it, and understand it, okay? Drugs are classified by use. They're categorized by their potential to be harmful. This includes prescription, non-prescription, and controlled substances. Controlled substances are a scheduled system, and they're monitored by the DEA. The FDA is in the process of revisiting how drugs are categorized for potential benefits and risks to the mother, fetus, and children. So we did not talk about that much, but know that for a pregnant mother, a drug that is safe for you and I may not be safe for that fetus. It may be, you know, deadly for that fetus. So that's another classification that is going to be taken into account, okay? FDA has strict controls for research, study, and production of drug substances. There are special programs to speed up the process for rare diseases or life-threatening conditions and provide for greater benefit than detriment from drug therapy. Three main phases of drug activity are pharmaceutic, pharmacokinetic, and pharmacodynamic. Principles involved in pharmacokinetics include the following. Does anybody know that acronym that I told y'all without looking? What's involved in pharmacokinetics?
ADME?
Yes, thank you, Brendan. I'm going to try not, you know, I was a cheerleader, so I really want to make up cheers, but I'm also trying to control myself. So I'm going to make up some cheers if y'all don't start remembering my acronyms without them. So ADME is your acronym that uses pharmacokinetics. Let's see. Principles of pharmacodynamics involve the biochemical movement of drugs into cells by the receptors on cells by altering the cellular environment around the cell to gain entry. That is one of the principles that I'm going to drive home a little bit more tomorrow with how the drugs react with the body, or tonight when I post that video for y'all. Adverse reactions to drugs can range from minor, which would be GI distress, to the most severe, which would be anaphylactic shock. Drugs interact with many foods and other drugs, resulting in reactions less than or greater than when given alone. Age, weight, sex, disease, and route influence a person's response. And herbal preparations, we didn't talk about this either. Herbal preparations are not considered drugs, yet they should be considered part of the medical routine. So herbal preparations are not monitored by the FDA, okay? But we still count them as drugs when we are obtaining drug history, okay? So like if somebody's having surgery, because I was a pre-op nurse, so if somebody's having surgery, we're going to have them stop their vitamin E because we know that it has a potential to thin blood a little bit, even though it's not a drug at all. I say it's not a drug at all, even though it's not a, they don't consider it on their drug list. They just take it because it's a vitamin, it's a supplement, it's a herb, and they don't really worry about it. But it's still going to affect their surgery and it's going to affect their other medications. So always ask about herbals in addition to meds. I have talked for a really long time. Questions, comments, concerns? Thank y'all for nodding, pretending like you were interested. I appreciate that because I can see y'all. No questions? Okay, I am going to ask that no one hang up until I push stop recording to make sure that it captures everything. No questions? Y'all feel good? Pharmacology chapter 1 in the books. Okay, I'll post some stuff for y'all later. I need anything? Going once, going twice. Okay, don't hang up yet. I'm gonna push stop recording. I gotta figure it out. All right. Stop recording.